Hey, welcome everybody. Dr. Gigi El-Bayoumi. I am delighted to welcome you to another Rodham Institute Impact Speaker Series. I'm so excited to tell you that we've got a great lineup today for Dr. Callendar, Clive Callendar from Howard University, giant in the field of transplant surgery, and Dr. Keith Melinson from GW's Transplant Center, the Ron Paul Center here at GW. But before we get started, I'd like to go ahead and just give you an update about what's happening. Just to remind you, the Rodham Institute is dedicated to improving health equity in DC, and we've been really busy. We have been busy because we've been working for now 7 years with our various community partners, and so when COVID hit, we really were able to hit the ground running. What we believe is in partnering together to improve the health and well-being of DC. As an academic institution, we are actually housed within the School of Medicine at GW, but we are here to serve the community at the pleasure of the community. And so our very first summit that we held 7 years ago, we asked, what is it that we should focus on when it comes to being an action-oriented institute focused on improving health equity in DC? And a resounding, unanimous call was to focus on education and food. We believe that health equity equals legal justice, equals economic justice, equals social justice, and as we used to say back in the day, one struggle, many fronts. We focus on three main issues: our youth education programming and workforce development. And actually before the webinar started, I was talking with Dr. Callendar about one of the giants that helped me get started in my medical school education, Dr. O.T. Randall, who is actually a pioneer in hypertension. So youth educating programming and workforce development to get as many children and youth interested in medical careers, whether that's to become a doctor, whether it's become a physical therapist, a nurse, an IT, whatever. It's important that we get the numbers do make a difference. We know that the more African American, Latino, people of color that are working as clinicians, as physicians, the better the health outcomes for communities of color. We also believe that it's important to train people who are in the current healthcare system now about applied health equity, to educate them about the social determinants of health. And finally, community collaboration. And this webinar series is but one example. Since COVID started, we've done 36 of these webinars on a variety of topics. We've partnered with 6 anchor institutions, 3 of them faith-based that include Temple Praise, Pennsylvania Avenue Baptist Church, Israel Baptist, as well as our friends at United Medical Center, UDC, and Southeast Tennessee Learning Center. We believe that it's important to educate the public on COVID when there are so many myths that are out there, and I'm going to just give you a brief update. Up until now in the District of Columbia, we have lost 601 people to COVID. 84% of those people are African Americans. So for anybody who's lost a family member or a loved one, I'm so sorry about your loss. But unfortunately, these numbers are going to continue to go up in the country. We're, I think, pretty lucky being in DC because our mayor actually follows the science, and she has been thoughtful in how she's reopened the city. Unfortunately, you know, we're a porous city, and so people come from other parts of the country. But for all, I think we're doing pretty well. But that doesn't mean that all of the different other illnesses that have been going on prior to COVID haven't continued. We are really caught right now in 2 pandemics: the pandemic of COVID and the 400-year-old pandemic of racism, which has had an acute exacerbation, as we say in medicine, with the serial killings that have begun, or at least have gotten public attention with George Floyd. Before we get into the topic at hand, I'd like to just say thank you to our wonderful staff. Ms. Ashanti Carter is the program manager. She's been instrumental in helping to put these webinars on. Thank you, Ms. Ashanti. Ms. Christina Williams, the Director of Community Engagement. She has been responsible for getting 2,200 masks delivered to different groups in Southeast that include children, families, the elderly, people in correctional facilities, teachers, as well as people working in clinical settings. She's also been helpful and key in getting over 2,000 hot meals and produce boxes distributed to those same groups. And finally, Ms. Tracy Bass, who's the Director of Help and Workforce Pipeline Programs. We just finished our middle and high school boot camp this summer, and I'm happy to announce that in October, we will be replicating my alma mater, University of Michigan's Doctors of Tomorrow program here at the Rodham Institute, so please stay tuned. Without further ado, oh, I forgot, I always forget this part because you can tell I'm not a social media person. We have all these different social media handles. Please keep in touch. Please share what we're doing. Please go to our website and you can see what we've done before. So without further ado, I'm going to start by welcoming Dr. Callendar. He is truly a giant in the field of transplant surgery. He's a professor of surgery at our sister school, Howard University College of Medicine. I'm just delighted to welcome him to our program this evening. And then my friend and colleague, Dr. Melinson, he goes by Keith, just like I go by Gigi, professor of surgery, chief of our Transplant Institute, and medical director of the Ron and Joy Paul Kidney Center. Welcome, gentlemen. How are you today? Oh, we need to have you on mute, Dr. Callendar.
Am I still on mute?
You're perfect. I can hear you. No, now I can't. Now you're back on mute.
Okay, I should be okay now, right?
Yes, you are. You are.
I thanks for the opportunity to be able to be with you. I'm thrilled.
Yes, thank you. Dr. Melinson, are you there?
Yes, can you hear me?
Yes, we can. We can hear you and we can see you. I love the Black Lives Matter in the background. Yeah. Well, you know, one of the real tragedies of the COVID pandemic is that there has been such a focus, rightly so, on COVID, but all the other illnesses that we know really are the drivers of premature deaths in African American and communities of color have really been largely ignored. There have been statistics that in the first several months of the pandemic, there was an excess death rate in the field that EMTs, emergency medicine folks have been seeing of something like 30% in excess death rate. That number has come down, but we're also hearing that the number of people diagnosed with cancer has plummeted, which is terrible because people might not know, but in Washington, D.C., we are #1 per capita in the country in cancer deaths, in HIV, and Dr. Melinson and Dr. Callendar in end-stage kidney disease. So how is the pandemic affecting people who are living with kidney disease? Dr. Callendar?
Sure. Well, it's interesting how this pandemic has caused us to focus on those diseases which already were the biggest problem in our communities. And so in many ways, it's been an opportunity for us to put into play and to put focus on the social disparities of health, which have already been killing us. But this then puts a highlight on it and helps people to recognize that we've got to do something. And the something we have to do is to address institutionalized racism wherever it is and try to wipe it out, because that's what's really behind why our people are doing so poorly. The 84% of people who died in DC is just horrifying. And if you've got end-stage renal disease and you get COVID, it's not good.
Thank you, Dr. Melinson.
It's interesting, sad, and Dr. Callendar has actually been at the fore of this for a very long time. You know, he led a whole mission in telling people in the community to take care of themselves, and what we're seeing is after a very long period of time where we have not had adequate healthcare access, and as you well know, food deserts and obesity, high blood pressure, diabetes, these are all the precursors to death with COVID. So African Americans are at a much higher risk of first acquiring the disease, the virus, but a much higher risk of death. And the key to dying with COVID is actually kidney failure. So the patients that develop acute kidney injury are the ones that tend to go on to death. And what is the main reason why you would develop acute kidney injury, even if you have no kidney disease when you get the virus? Well, it's all of the precursors that lead to kidney disease normally: diabetes, hypertension, obesity. So obese minority patients have the highest risk of death. They have the highest risk of acute kidney injury. So kidney health is directly related to the mortality from COVID.
Well, I've been on doing these webinars. We actually have one coming up with our internal medicine academic organization. And I say that this is just the latest example of poor outcomes and worse outcomes and death and destruction in communities of color. But Dr. Callendar, I just have a question. You're senior to us. I hope I'm not that far behind, or the baby Dr. Melinson there. But given your career, especially, what have you seen that has changed or not changed in terms of addressing these inequities that really beleaguer our health system?
Well, I think this is an opportunity for us to recognize that we have not been doing due diligence in addressing these social disparities of health. And in case we had any doubt about it, I think this is telling us once and for all, you've not done it. And so in order for you to be prepared for the end of this and the next one that's coming, we need to wipe out institutionalized racism and address these social disparities of health so that we bring up the level of access for all, which we have not done.
So just for the audience to remember what those social determinants of health are, they include the water that you drink, the air that you breathe, the food that you eat, where you live, your educational level. We often think that just having access to healthcare really determines how long we're going to live. But the reality is that only accounts for about 20% of all health outcomes. And although we are very proud of our profession as physicians, we really don't contribute that much. In Washington, D.C., according to the Virginia Commonwealth University study that I would really urge viewers to look up, if nothing, just to look at the graphics. It's called Uneven Opportunities. If you live in Georgetown, your average life expectancy is 94 years. If you live in Anacostia, you can expect to live on average 66 and a half years. That's almost a 27-year differential in a city that is 10 miles, a span of 10 miles. I mean, that is shameful. One of the other key determinants of health is our education. So in Ward 8, when there are 42% of kids that are graduating from high school, and if we as physicians, all we did was to get kids to graduate from high school, we would add 10 years of life to their life expectancy. There are not that many things that we do that can automatically add that much in terms of life expectancy. So I'm going to turn to you now, Dr. Melinson, and really I'd like to first of all know what you've been doing sort of prior to the COVID pandemic, and then how your work has been impacted by COVID.
Yeah, thank you, Gigi. So first of all, it's hard for me to be on a panel with two mentors like you and Dr. Callendar, because I believe that so much of what I'm doing, I'm only doing because of you guys. And as you know, our entire organization was based upon the grassroots sort of organization that Dr. Callendar started with his organization, MOTEP, which he modeled on the civil rights movement. You know, I have a funny story to tell you. When I was at Hopkins, I remember we used to have these deep intellectual conversations, and we invited Dr. Callendar down to give the grand rounds once. And he started with his first slide as to trying to get across to the audience why we would see more kidney disease in African-American patients. And you would think in such a cloistered setting that Dr. Callendar would have been very careful in how he unspooled the story, but he just came straight out and said, institutionalized racism. And I'll never forget that, because, it was, here I am, the only person of color in the audience, and I'm like, oh my goodness, whoa, this man is he's just bold. But, he was absolutely right. This was decades ago. And, this marvelous new militancy that's engulfed the community, these young people are saying exactly what Dr. Callendar said, and has been saying for his entire career. So I'm so proud of the fact that we have modeled our organization, the Ron and Joy Paul Kidney Center, behind what he did with MOTEP and what we were doing prior to COVID, and we're continuing our work, but it's been hamstrung a little. We have been going into the community with the lessons that Dr. Callendar taught us, and what he said was, meet people where they are. It makes no sense. When I was at Georgetown, we were doing outreaches in Georgetown. You're not gonna, like you said, you're not gonna meet the community that needs access unless you go into that community. And again, the civil rights movement, what they did to get people to be excited about trying to vote, they went to the churches, they went into those Black communities in Mississippi and Alabama, and they did the hard work. The people that wind up getting on television wind up getting all the glory, but really the tough work was the grassroots organization. What we have done that I'm so proud of is we've gone into the community and we have shown people in the community how much at risk they are for kidney disease by starting early, not waiting until blood tests show kidney disease, but educating the community to say, you know what, with all these precursors, high blood pressure, diabetes, things that you don't think, or even pre-diabetes or pre-hypertension, things that you don't think are an issue, guess what? It's already starting to manifest as kidney disease. We're showing that they have proteinuria. Proteinuria is the first stage in kidney disease. So what we have to do now, that's what we were doing prior to COVID. We haven't been able to go into the community and get the urinalysis done like we were doing prior to this. But what we're doing now is we're trying to do a lot more online and do a lot of this teaching and trying to get out in these new mediums that the young people have taught us is how they're able to get their message out so effectively. So we've been doing a lot of this telemedicine stuff and a lot of education by Zoom or whatever the medium is. And in that way, try to educate people about the precursors to kidney disease and show them, like we talked about COVID, how kidney disease leads to premature death in a manifestation of many ways.
Well, you brought up an important point, and that is sort of the telehealth and teleeducation. Unfortunately, the digital divide is real, and it disproportionately impacts our communities in wards 7 and 8. I was on the Reopen DC task force that the mayor put together, and our recommendation was to get broadband to the entire city. That would help with internet access. It wouldn't necessarily help with computers or even computer literacy. I think one of the things that many people don't recognize is that 1 in 3 Washingtonians are functionally illiterate. And so it's so important that in our work, we diversify. And yes, of course, right now we have to do things by internet and Zoom, but I know that you have been working as well with the Pennsylvania Avenue Baptist Church under the leadership of Dr. Reverend Curry to sort of train others to train others. And so that, you know, sort of this idea of really increasing the capacity of the community itself. But I would like to ask you a question, Dr. Callendar. You chose an Egyptian name for your organization. Can you tell me the origins of that and who that person that you named it for was? Can you give us a little history lesson?
Interesting that you would ask, because actually Curtis Yeager and I work together, and it actually stands for the National Minority Organ Tissue Transplant Education Program. And actually it doesn't stand for any person. It was named just after that. And we added national to it because it is a national organization, but it's a National Minority Organ Tissue Transplant Education Program. And MOTAP is simply that, and not named after anyone. It's actually an eponym that is used to describe what we're doing about organ and tissue education. You know, I wanted to take a moment to say something about what Keith is talking about in terms of recognizing this is a new opportunity to find a way to get into the community in spite of the obstacles that COVID presents. And I think one of the things that is attractive is that maybe what Dr. Melanson and the group is doing may be the way in which the future will recognize ways to overcome the fact that, for example, COVID is making it difficult to have the face-to-face grassroots interactions. But that just means it's difficult, doesn't mean it's impossible. It means that we may need to be more creative and innovative in ways of trying to reach the community in spite of the obstacles that COVID is presenting to us.
So what do you see in terms of the patients that you're seeing right now that are present for, you know, before we even get through that, you have really worked, both of you, on allowing a greater access, especially to minorities for kidney transplant. Can you talk a little bit about the approach that has increased the numbers of transplants? How did you get the idea of doing this? Why has it been successful? And what does it take really to educate the rest of us about the importance of donations, kidney donations?
Well, you know, there's two aspects of it. One is the things that I do, and the other is the things that Keith does in his group. And I'll tell you about the things that I've done that have been strikingly effective. And as Keith had mentioned, we modeled our program after SNCC, which John Lewis and his group developed, because it would go into the community and go into the churches, go into the social groups, and then by that means have a face-to-face encounter and educate and empower. In addition, what we did was to go into the community and let the community do the work. We didn't do the work, the community did the work. We educated and empowered them to go into the rest of the community by their own means and make a difference. And so this then was the modus operandus that allowed us to go from the bottom to the top. It was kind of interesting because when actually Keith and I were at a meeting, and it was 2017, and at that time, African Americans were getting closer to the top. You know, we were at the bottom when we started, actually, in our efforts in the 80s. But when we looked at the data, it was to my shock when Keith and Naru Kozimi pointed out that African Americans were the #1 organ donor per million in the United States of America. That was astounding to me. And that has happened because of our efforts to go into the community, educate and empower the community to make that difference that must be made. Now, so that's my perspective. Keith is doing something that's very different in many ways. He's using creative and innovative efforts to make transplant accessible to people, minority people who wouldn't otherwise be transplanted. And he can tell you how he does that.
Dr. Melinson?
Yeah, so, it's interesting, Gigi, because first of all, I heard Dr. Callendar snicker a little bit when you talked about the illiteracy in this city, because I think I heard him say something about illiteracy in the White House. But, I wanted to get back to the question you asked him, because the great Imhotep, which I think you were alluding to, was of course Egyptian. Callendar is kind of an Imhotep. I think for young people out there, what they need to realize is, obviously we are physicians, Dr. Callendar and I are surgeons, but at heart, this is a man driven by a philosophy, right? So, you look at Imhotep, who was a Renaissance man long before the Renaissance, and he was a man driven by a philosophy. So I think as I, meet medical students and I know, Gigi, you do a great job of mentoring so many of them. That's what I try to impart to them is, you've got to be driven by something internal, right? And that's when I look at my great mentor, that's what he's done throughout his career. Now, you see the Black Lives Matter poster there, but one of the things I hope that these young people today really embrace is what Dr. Callendar alluded to. SNCC and the Civil Rights Movement, at the end of the day, could point to legislation. They changed the world and it was tangible, right? And when we start talking about transplant, I want to tell you, Dr. Callendar and other people like him in the transplant community really changed the way we did transplants as far as access. One of the things that happened was giving people wait time for being on dialysis. For years, African Americans in particular did not have good access to transplant because they just wouldn't get referred. But now, if you are on dialysis, all that dialysis time actually becomes wait time as soon as you're listed. And that's a huge advantage for minority patients. One of the other things that used to happen in transplant was we have, HLA matching, and you're going to be better matched by HLA based on your ethnicity. So because this is a majority white country, most of the donors, at least, back in the 1980s and 90s were white, and therefore most of the kidneys available were better matched to white people. That was one of the ways that we were basically discriminated against. Dr. Callendar and, again, others of like mind got these rules changed. It was very, very tangible. And that's why today we are much closer to equity once we get on a transplant list. Now, there's still issues getting onto the list, but once you're on a list, there is good equity for Black patients. But that didn't just happen. People didn't just do the right thing. They had to be shown what was the right thing. And I think that's the lesson for young people today. Now, I was able to ride on the coattails of people of Dr. Callendar's generation. And now what we're trying to do is address the issues that are at present because of the fact that African Americans tend to be on dialysis longer and they tend to be exposed to human antigens. That brings us in, and what we have to do is we have to find better matches. We do this stuff called desensitization, And the hallmark to desensitization is actually one of Dr. Callendar's precursors as chairman of surgery at Howard, the great Charles Drew. Charles Drew, famously, people think, oh, he came up with blood transfusion. But what he really invented was separating red cells from plasma. That's exactly what we do when we desensitize people. We separate their plasma, take out their antibodies. So I believe I am carrying on in that great tradition of Drew and Callendar and other, icons, Martin Luther King, all the big ones.
So, I just want to stop and tell you a story about this young man that I met at Berry Farm about 5 years ago. We had done a health fair there at the rec center. And this little boy, he's 6 years old, was sitting reading a book. And so I sat next to him. I'm like, oh, what are you reading? He said, I'm reading about Dr. Charles Drew. And so he said, did you know that Dr. Drew is from DC? I said, yes, I did. Did you know that he, invented the blood bank? I said, yes, I did. He said, did you know that Dr. Drew was in a very bad car accident and he went to a white hospital and he was bleeding, and he got refused care? I said, yes, I do. And do you know that Dr. Charles Drew, by the time he got to the Black hospital, died? I said, yes, I do. So we've brought this young man who's now 9 years old, Tyler, and we have had him speak to our medical students and interns to help educate them about the history of the great Washingtonians and how racism is not just sort of an abstract. People have literally given up their lives. And Dr. Drew, of course, is but one of the giants out of Howard University, the late Dr. LaSalle, of course, and others. But Dr. Melinson, please describe your program where you get 20 different people that may not be related to each other, but can help get their loved ones a kidney. Can you describe that for us?
Yeah, well, first, I have to give credit to my colleagues at Johns Hopkins, because, when I came out of fellowship, my first job was at Johns Hopkins, and it was just the perfect place for me to be. And we started to do these paired exchanges there, and it really started with the pediatric nephrologist. The pediatric nephrologist, because as you might imagine, parents will not watch their children just die of kidney disease. So they were really at the point of the spear in pushing these innovative therapies like plasma exchange. Well, first it was splenectomy, then plasma exchange, and then paired kidney exchange in order to get these children transplanted. It was one of the enterprising surgeons in transplant at Hopkins, Bob Montgomery, who wound up marrying a Washington icon, Denise Graves, the great opera singer. But Bob Montgomery was my boss at Hopkins, and we started doing a lot of these desensitizing things and paired exchanges. Now, me being me, I after being there a while, I started to criticize the team because I said, now here we are, we're doing all of these innovative things, bringing people from all over the world, and I can walk out the front door of Johns Hopkins into East Baltimore, which has one of the highest, next to DC, one of the highest rates of kidney disease in the country, and we're not helping those people. Why aren't we helping them? And but to their credit, my colleagues said, well, Keith, you know what? Let's try to concentrate on that minority community in Baltimore. And that's where I started this new concept of taking those cutting edge therapies to try to increase access to transplantation for minority patients. And interesting as it may be, the patients that have more of these issues than anyone else are minority patients. Why? Because like I said earlier, we sit on dialysis longer. The longer you sit on dialysis, the more likely you are to build up these antibodies. Number two, as you go down on the socioeconomic ladder, you're going to have less options for transplant. You know, if you're, let's just throw a name out there. If you're Kanye West or Kim Kardashian and you say, I need a transplant, everybody is going to be trying to donate to you. But if you're a poor person from across the Anacostia, you're not going to have that many options. And if you do have an option, it's probably a single option. And what we need to be able to do as a community is make that option work. So that's why what I was trying to do is make these live donors work when they had limited options. So Dr. Callendar had done so much in the deceased donor area. What I concentrated mostly was in the live donor area and taking these African Americans and allowing them to have live donors. Now, one of the statistics we're so proud of here at GW is about 11% of African Americans get live donor kidney transplants nationwide, although we make up about 36% of the patients with end-stage renal disease in the country. So we have a lot more kidney disease than we make up the population. However, we were only getting about 11% of the live donor transplants. Here at GW, of the live donor transplants that we do, 45%, almost 50% of the live donor transplants go to African Americans. And why is that? Because we have these cutting edge sort of techniques, everything from desensitization to doing ABO incompatible transplant. And you know what, honestly, it starts with the concept. And the concept is Black people can be good kidney donors. Let me tell you, that seems so obvious, right? In our field, it is not that obvious. Dr. Callendar can tell you that there is a presumption that African Americans will not be good kidney donors because we have more kidney disease. So even if we don't have kidney disease, there is this wall in the physicians that work in this area of thinking, you know, all they're looking for is an excuse to say, no, this guy cannot be a kidney donor. And you could have the exact same issue with a Black postal worker who's a little overweight and has a little bit of high blood pressure, although I always say there's no such thing as a little high blood pressure, but he's on one medication for his high blood pressure, and he will be quickly turned down at many centers. And you could have a white woman who works as a professional and is taking 2 blood pressure medicines, and she's quickly approved to save the life of her sister. You know, no one ever thinks about the fact that this Black man's brother is going to die, but you know, it's what we're fighting in this country now, right? Elevating minority people to having the same sort of effect on society about our lives, right? Our lives matter. The lives of our children matter. The lives of our loved ones matter in the same way as the lives of everyone else. And I think that is what we're most proud of, because that's where it starts. The team has to buy into the concept that we want to save our loved ones just like they do.
Well, and I think, you know, what you're illustrating so eloquently is the importance of several factors. Sort of at the core of it is education. Because if none of us on this panel were educated and became physicians, we would not have the voice to actually advocate, to do the research, the science, the surgery, all of that. So Dr. Callendar, you know, before we went on air, I was talking about Dr. O.T. Randall, who, as I mentioned, is sort of a god in the field of hypertension, University of Michigan graduate. He interviewed me for medical school. He was the reason that I got into University of Michigan. Please, you know, I mean, sometimes I think that, you know, there is the hubris of youth that they think that they're discovering everything and everything is new. But I know, certainly because of my age, but also my Egyptian heritage, that there's really nothing new under the sun. Please talk to us about what, you know, your educational endeavors and increasing the number of minority faculty, being a mentor to people like Dr. Melinson. Why is that so important? Why does that matter?
It's difficult to overemphasize the importance of mentorship. You know, Dr. LaFall and I started mentoring junior high school students and high school students who today are physicians and surgeons. And there's nothing more exciting to me when I get a call, and I get them every now and then from people who I had in high school, and because of our mentorship, who now are physicians and scientists. And some of them didn't become physicians, some became scientists. But you know, I also have to correct a myth that that is spoken about a lot, but is not accurate. And that is about Charles Drew.
Thank
Some
you.
of the fall actually went down to the hospital where Charles Drew died. And Charles Drew was so banged up in that accident that he did not bleed to death. He had head injuries and neck injuries that really killed him. So it wasn't the fact that he didn't get transfused, although that is the myth that is attractively spread around, but it is not accurate. I just wanted to say that about it.
Well,
Because,
thank you. Thank you.
yeah, because there
Yeah.
have been books that have been written that inaccurately addressed it. But actually, LaFall went to that hospital and talked to the anesthesiologist and the surgeons. And they actually came to his office and explained to him how badly injured Charles Drew was in that accident, so that it wasn't blood that lost that killed him. But that's the myth. But anyway, yeah. But mentorship, you can't overemphasize two things. One, the importance of mentoring people of color. The other thing is recognizing that people of color, taking care of people of color, is equally important. And that's something we haven't mentioned today, but there's data that makes it clear that there was an interesting article that came out, which is horrifying, that indicated that the chances of a black child dying if he's taken care of by a white person versus a black person is 3 times that of what it would be if he was taken care of by a physician of color. So it's not only important for us to mentor, it's also for us to go into communities of color ourselves, because we make such a difference.
Well, you know, back in November 2013, the National Medical Association issued a white paper on the state of African American health, where they basically brought all the literature together that shows that Black physicians, especially Black males, Black male doctors taking care of Black males, absolutely improved life expectancy. And for those audience members that don't know about the National Medical Association, that was founded over 100 years ago now, when Black physicians were refused entry into the American Medical Association. And so before there was such a thing as health equity or health disparities, the NMA has been doing this work. You know, all these catchphrases that are getting all this attention, people have been doing it. Black physicians, minority physicians have been doing it for decades. So I'm going to come back to you, Dr. Melinson. Tell us about that like chain transplant thing that you have. Can you describe it to us? I don't know how to use another term. Please take us through what that looks like.
Sure. Yeah, you know, but I have to address the Charles Drew thing, because, like I said, it's such an important part of what I do every day. And Dr. Callendar is absolutely right. He did not die needing a blood transfusion. However, the reason why the myth, which I heard as a kid when I used to watch MASH, which is one of the reasons I became a surgeon, Charles Drew actually resigned from being head of the American Red Cross, because the process that he created, which was, like I said, separating plasma from red cells, which allowed blood to be banked, right? So there was no banking of blood before Charles Drew. It didn't exist. He basically invented it, okay? After this Black man invented blood banking, the Red Cross then, years later, because of pushback that they were receiving from the American South, said, we are going to segregate blood. Black people can only get Black blood, and white people can only get white blood. Now, the hospital that Dr. Charles Drew died in was in the American South, and blood was segregated in that hospital. Dr. Callendar's right. No amount of blood would have saved his life, but they were still racist and would have, and had he needed a blood transfusion, he would not have been able to get it because they did not have black blood at that hospital. So although it is a myth, it's not a myth that they were racist and would not have given him white blood.
Yeah.
Although Charles Drew, just to show you the fallacy of race, had white skin, right? Like so many people in my family that are lighter than you, Gigi.
I know.
That's another point, right?
Yeah, well,
But
I've got
anyway,
people in my family that are darker than you, Keith.
yeah, exactly. Yeah.
Egyptians
Because,
are all colors of the rainbow. So, although
and
many
you might as
people,
well say that because since so many of Americans are misinformed, Egypt is in Africa.
well, listen, because of our civilization, they try to make us honorary whites, which we are not.
Right. Yes,
We're
I know.
African.
But anyway, so the paired exchange, again, I think it's one of the most beautiful things that we see in medicine, because what has to occur is, first of all, in all of allopathic medicine, there is nothing like a kidney donor or an organ donor, period, right? Particularly a live organ donor, because, Hippocrates, again, another person built on the history of Imhotep, but Hippocrates said, first, do no harm. Well, if you're an organ donor, you're getting harm done to you, right? I mean, there's no good coming out of you allowing a surgeon to assault you in order to help someone else. It is an assault. I mean, it's obviously surgery and it's done in a very civilized manner, but you're not helping that donor. In paired exchanges, it goes even beyond that, because, here, you have a scenario where, my wife needs a transplant, but she's built up antibodies to me because she's had my children. I want to give her my kidney, but I can't. So in a paired exchange, what happens is I give my kidney to someone else's wife so that my wife can get a kidney from some other person, right? And then what we found was that in these incompatible sort of pairings, it made sense to open it up to greater and greater numbers. Again, I have to give credit to my friends and colleagues at Hopkins, because they taught me the procedure. But, by the time I got to Georgetown, and again, opening this up to the minority community, a community that had an increased need, the size and scope of the paired exchanges increased. And that's why I was able to actually do larger exchanges than even my friends at Hopkins. The largest one that I've done was 16 transplants, and we did them in a few days. So you can imagine that's 32 operations. And what was so novel about that huge world record-setting exchange is that it should have fallen apart. And most people don't know this story. I remember we were already, since we were going to be setting the world's record, we were being interviewed by CNN and a lot of national, international media predicting that we were going to do this huge exchange. And the 2 nights before the exchange started, the person who was kicking off the entire exchange, she received a deceased donor offer. And it was a great deceased donor offer. Now, here I am. I'm about to set the world's record. I'm going to be interviewed by Sanjay Gupta and all these, Washington Post and everything. And I have to make a decision, and it's kind of like what I was saying about Dr. Callendar being driven by philosophy. And so the coordinator is on the phone telling me, yeah, this lady has a 18-year-old offer. What do you want to do? And I said, well, what do you mean? We have to do the right thing. We have to do the deceased donor transplant and unravel the exchange. That's okay. You got to do the right thing. So that's what we did. Well, when the lady comes in to receive her transplant, her husband looks at me and he says, yeah, we were supposed to do this exchange. You know, I'm supposed to be donating my kidney in 2 days. I'm still coming in the morning to do that. And I was like, no, you know, obviously this undoes everything because you don't have to donate anymore because your wife is receiving a deceased donor. And he said, no, Dr. Melanson, I'm going through with this exchange.
Wow.
And
Wow.
that's how that 16
That's
women
amazing.
went, you know. And so, you know, we've been blessed throughout this whole experience. And I think Dr. Callendar would say the same thing. You realize from dealing with patients, not only what the trials and tribulations that they have to go through, but seeing the best side of mankind. You know, so much of what happens today is the worst side of mankind. But to see people, I just did a non-directed donor the other day. This kid walks in and says, I just want to give my kidney to someone. I just want to save a life, you know? And we meet these people all the time. In that 16-way paired exchange, we had 4 non-directed donors. Four people like that just said, I just want you to take my kidney out and give it to someone to save a life, you know? So
Well,
I am very proud of that, you know?
Yeah, that's an amazing story. And actually one of the young women that was the photographer working at GW, she's since gotten another job. She was one of those people, young woman, young white
Right.
woman. And she said,
Right.
I want to donate my kidney. And I'm just going to correct you on something, Dr. Melinson, with all due respect. You said the worst of mankind. Well, maybe that's the problem right there. Maybe that there isn't a womankind here. Maybe it's time to get some feminine power in the room. Not women just for the sake of women, because look at Nikki Haley's a woman, right? But women in terms of compassion and kindness and inclusion and care and love, which are feminine energies that both men and women have. Well, we're about to wrap up. We have a couple more minutes, and I want to give you, Dr. Callendar, the last word. You've been working in this field. You've really seen a lot of changes in some ways, some changes that seem to have been have come about, and then we find out that we're really not that, we haven't changed after all. But what would you sort of say to give everybody hope in the listening audience? What charge would you give us as physicians, as members of the community, as people who love our fellow human beings?
Well, it's interesting that you would ask me that question because to me, the essence of my whole life is that with faith in God, there's no impossible dream and there's no mountain that you can't climb. I think of myself as a kid growing up in Harlem, had tuberculosis at a very young age and had half my lung removed. So that I'd be the last person you'd think would wind up to be a transplant surgeon and to make a difference in transplantation. And then to see a miracle, which I call a miracle, to see that what I've done has impacted donors of all ethnicities, but especially the African-American community, to see that that could happen and that I could make a difference is a dream come true and something that I never would have thought would be possible. But so I've seen the impossible become impossible in my life because of my faith in God. And so that is the essence of me. What makes me, what drives me, as Keith said, something's driving me. Well, that's what's driving me, to be the best that I can be and to recognize in my life, I've seen so many miracles, just as Keith has described miracles that he's participated in. Whether he calls them that or not is another thing. But to me, it's all a gift of God.
Wow. Well, I just want to say what a pleasure and honor it's been to have you both as guests of our Rodham Institute Impact Speaker Series. Dr. Clive Callendar, Professor of Surgery, Transplant God, Guru. Dr. Keith Melinson of GW, also transplant innovator. Thank you so much, gentlemen. And I think the closing point is pay it forward, whether we pay it forward by donating our own kidneys so that other people that are strangers can get them, or pay it forward by educating and mentoring, but it is about paying it forward. So on behalf of the Rodham Institute, thank you for your participation, and please stay safe and healthy. Thank you. Take care. Bye-bye.
You too, Gigi.
Bye-bye.